Hello everyone, our topic of discussion today is skull base fracture. In earlier chapter we learned how skull vault gets fractured. See, whenever there is any trauma, simply trauma of any bullet or rod, the skull vault gets fractured. But for the skull base to get fractured, there has to be a different type of trauma. See, whenever a person falls from a height and lands on feet, or falls from height and lands on buttocks, the pressure is transmitted from here to the sacrum to the vertebral column and to the base of the skull. So entire pressure that is felt here is going to be transmitted around this foramen magnum. So around the foramen magnum we will have a ring shaped fracture. So this is what ring fracture. It occurs 3 to 5 centimeter around foramen magnum, which is located in what? Posterior cranial fossa. So this was about the skull base fracture, and it needs what? An indirect impact. A direct trauma cannot cause a skull base fracture, right? The second one is a hinge fracture. See, in hinge fracture what happens is a trauma occurs in the lateral side. Whenever a lateral trauma occurs, there occurs hinge fracture, and there are three types. Let's learn all these three types individually. See, just look at the diagram. In the diagram we can see the type 1 is impact in the middle cranial fossa. Whenever this sideways impact in the middle cranial fossa, the fracture line goes from middle cranial fossa to this sphenoid bone and to the other side of the middle cranial fossa. So sorry, not sphenoid bone, sella turcica, which is pituitary. So the fracture line occurs in this lateral part of the middle cranial fossa and goes all over. This was type 1. Type 2 is whenever a posterior impact occurs, then the fracture line goes from posterior to anterior cranial fossa. This is type 2. Type 3 is sideways impact in the anterior cranial fossa. Type 3 is just like type 1. The fracture line just runs in the anterior cranial fossa. So the type 1 is what? Middle cranial fossa. Type 2 is posterior to anterior, going through what? Sella turcica. And type 3 is in the anterior cranial fossa. Done? So now there is another thing called nodding face sign. It occurs in a hinge fractures. Let's say a motorcyclist is driving very fast and it encounters a sideways impact, which is very common in a motorcyclist. So in that situation there is a skull base fracture and there is a nodding face sign. The patient presents with the nodding of the face, which is abnormal mobility of the base of the skull. So this was hinge fracture. So now we have learned two type of skull base fracture. Now we'll see the clinical features. See, in this diagram you can see that this is a skull base, right? Whenever this gets fractured, this fluid over here you see, it's cerebrospinal fluid. This fluid will come out either through the nose, which is CSF rhinoria, or either through the ear in this part, which is CSF otoria. So the clinical feature of skull base fracture is what? The CSF rhinoria and otoria. So just visualize this image, visualize the CSF over here coming out through the nose and the ear, right? So now how will we say that the thing which is coming out of our nose over here is CSF only? It can be mucus, right? So the CSF have some peculiar characteristic, like it has increased glucose and decreased protein, and the gold standard for diagnosis that it is CSF only is beta 2 transferrin. It is a specific marker for CSF. So now we are studying clinical features of anterior, then posterior, and then middle cranial fossa separately. Now see, in the anterior cranial fossa clinical features, there are 6 to 7 clinical features. So we can't just memorize the written text over here, right? So we'll draw a image and mark every clinical features in that. So this is our image. We are studying what? Fracture of the anterior cranial fossa. So the first one is here, you can see the blackening of this eye. So this is periorbital hematoma. So fracture has occurred in the brain where the anterior cranial fossa is there, but the blood has extravasated or come down due to gravity to this space. Why this space? Because it has the fat which can usually accumulate this blood. So periorbital hematoma. Second is CSF rhinoria, CSF coming out through nose, which we already saw that the anterior side comes out through the nose. So first is periorbital hematoma, second is CSF rhinoria. Third is halo sign. See, what is halo sign? Whenever the CSF comes out, there is a bit of blood also. So in the halo sign, the center one will be blood and the outside of the blood, the peripheral part will be CSF. So halo sign is blood tinged CSF forms a halo on cloth. So whenever you take this on a cloth, the center part will be CSF, sorry, center part will be blood and outer part will be CSF. So it's a halo sign. The last two features are there is bleeding on the nose and paresthesia at the tip of the nose. So we can just learn these five clinical features by visualizing this diagram. You don't write this 10 times and run. Okay, just visualize this diagram. First is periorbital hematoma, CSF rhinorrhea, tingling and numbness, sorry, bleeding at the nose, and paresthesia at the tip of the nose, and halo sign. Okay, so in the same way we'll study clinical features of middle cranial fossa with the help of a diagram. First, let's look about posterior cranial fossa. See, in the posterior cranial fossa, there is only one feature important for you, which is boggy swelling in the neck. Just see, whenever there is fracture over here in the posterior cranial fossa, the neck will be a bit swollen due to blood and some fluids. Okay, so we have boggy swelling in the neck. The middle cranial fossa clinical features will use learn this with the help of this diagram. See, the first is the Bettel sign. The anterior cranial fossa had what? Ecchymosis near the eye because the blood was coming at this eye. In the same way here the blood is coming at the mastoid process. So we have Bettel sign, which is the ecchymosis at the mastoid. Okay, second is hemotympanum. Let's say this is a tympanic membrane. So behind this tympanic membrane there is a blood clotted, which is called what? Hemotympanum. The first feature is Bettel sign, second is hemotympanum, third is facial nerve palsy. Just imagine a facial nerve over here which is getting affected. So we have facial nerve palsy. Last one is CSF rhinorrhea. CSF coming out through nose. See, in the anterior cranial fossa fracture, there was also CSF rhinorrhea. CSF was coming out through the nose, but here the CSF is coming out via eustachian tube and then to nasopharynx, and from over there to nose. The path is different, right? The clinical presentation is same. CSF is coming out, but the path is different here. And the last one is CSF otorrhea. This is more important than this. The peculiar feature of middle cranial fossa fracture is CSF otorrhea. Okay, so just we'll just summarize about these clinical features from this diagram. The first one is Bettel sign, second one CSF otorrhea, third one imagine this here. So hemotympanum, blood clotted behind tympanic membrane. Second one facial nerve palsy, and CSF coming out of the nose, CSF rhinorrhea via eustachian tube. Done. So this was middle cranial fossa. So now we have the last topic of discussion over here is cope and counter cope injury. See, let's see, this guy strikes his head over here. So this is what a primary impact. So whenever there is an impact here, this brain will move in this direction due to inertia, and whenever the brain will hit over here, then there is injury in the brain due to this rough surface of the skull. So this is primary impact, which is cope. And where it is happening? It is happening in the brain. So the cope happens in the anterior part of the brain, or the part where there is impact. So the brain strikes the skull, this part, and there is impact. So this is scope. But when the brain hits here, it also then goes back. And after it goes back, you can see that whenever this brain goes back, there is the space over here is reduced, right? So there is a vacuum created which will suck or pull the brain. Why the vacuum is created? Because the brain is going back due to its inertia. When the brain goes back, the space, see, this is brain and this is skull. We are looking at the posterior side. So whenever the brain goes back due to inertia, the space is decreased, right? This decreased space creates the vacuum, and this vacuum will suck the brain over here. This is what the struck hoop theory or vacuum theory, which will cause injury to the brain in the posterior part, or the part which is opposite to the impact. The part of the impact is this, and the opposite part is this one. So this is called secondary impact, or more importantly counter coup injury. And the ironic part here is this coup injury which happened at the impact is mild, while this counter coup injury is severe, which happened at opposite to impact. And these injuries are happening where? Are happening in the brain. Okay, not the skull. We are not talking about the skull, we are talking about the brain here. So we have struck hoop theory or vacuum theory. So now let's see, Now we are comparing the impact side. See, whenever there will be a occipital impact, then the coup injury will be where? In the occipital part of the brain, and the counter coup will be on the opposite side. So it will be on the frontal lobe. Why? Because there is a this surface of the brain is rough from inside, so it is causing a frontal lobe contusion. Okay, this you understood. Now there is one exception to this rule. Okay, only one exception. The exception is whenever there is the impact is on the frontal lobe. So let's say the impact is here, then the coup injury will be where? Over here only, but the counter coup will be on this part. But it does not happen. Why? Because this posterior part of the brain is smooth, or the skull inside is smooth, so the counter coup at the occipital part does not happen. So no injury in the occipital lobe due to smooth region, right? Whenever, let's come at the temporal lobe. See, in this diagram you can see this is the temporal lobe. So whenever there is a impact over here, then the coup injury occurs here, and the counter coup occurs here, right? Because the brain will hit over here. But the counter coup can also occur ipsilateral part. This is the part where the impact happened. In here also it can occur due to this falx cerebri. The brain hits over here. So contralateral temporal lobe, or either contralateral surface of ipsilateral lobe, can also have what? Counter coup injury. Done. And the counter coup injury that I studied does not occur at the occipital lobe because this surface is smooth. So frontal and temporal lobes are more prone to counter coup injuries due to rough surface of the base of the brain. Done. So counter coup injuries are rarely seen in children less than 3. Why? Because the skull is pilable. So whenever there is a, let's say this is a skull of a child, whenever there is a trauma it will bend rather than pushing hard over the brain surface. So it's rare in less than 3 years. What is the mechanism? It has to be a mobile skull. A stationary skull doesn't cause a counter cope injury, and it is also seen in other organs like liver, lung and spleen.